That was great. Thank you so much, Sina. So now we can get into the Q&A segment. So please submit your questions in the chat window, and we have some already. So just going back quickly to the previous questions. One question, post PRP frozen shoulder. What is your experience, Dr. Latsko, with that, and how do you deal with it?
Yeah, well, this is one of the diagnoses where you don't need to worry about that because they already are frozen. So, uh, but my experience with that is particularly, you'll see that when you're injecting rotator cuffs most of the time. If you're injecting a rotator cuff tear with PRP, that's probably going to be your most painful shoulder PRP injection, and they just won't want to move for the next few days, and that's your main risk. I've seen it probably 3 times, but not that often. I think my partner's seen it probably a little bit more than that. I think the higher amount of platelets you use is going to increase the chances of that happening. So you're going to get more inflammation if you're using over 10 billion. I don't think you need to use a 10 billion, platelet count if you're injecting a tendon. Studies from that Dr. Bowers presented on recently show 5 to 8 billion is probably the range you want for most tendons. So my key would be like, don't you? This is where like, measuring helps because sometimes you don't know. The patient comes in with 350,000 platelets per microliter, and they're gonna, even if you're in your 60 cc draw, you're gonna get 15, 16 billion platelets, and if you're injecting that into the cuff, yeah, you're probably gonna get frozen shoulder, and that might be why I'm not getting as much because I've done hundreds of shoulders over the last few years, and 3 is not a high rate. When I do get them, and I do talk to my patients that is a risk. If they get a frozen shoulder from a rotator cuff injection, I'm usually telling them to come back in a week later and I want to examine them. I want to know if this is truly frozen shoulder, if they're already losing range of motion, or if this is just pain inhibition from their PRP. Uh, and if it feels like a true frozen shoulder, then we're injecting steroid. We have been injecting steroid in there as soon as we can. Now, not into the cuff, but into the joint. Is that going to negate the potential benefits of the PRP? Maybe. If it's a full thickness tear and articular sided tear, probably. But if it's an intrasubstance or bursal sided tear, maybe not. Uh, that's kind of my experience with it. I haven't had it happen with intra-articular glenohumeral joint injections. I haven't had it happen. Yeah, it's been all with rotator cuffs.
Okay, great. And can you just talk a little bit about lidocaine and whether or not that may affect the biologic
Yeah,
negatively?
that's a good question. Something we addressed in our recent guidance statement. A lot of that is, I don't think there's a clinical study out there showing that it actually affects clinical outcomes thus far, but there's lab data showing that lidocaine is bupivacaine is more chondrotoxic, uh, but lidocaine as well, and ropivacaine the least chondrotoxic, also toxic to the platelets. So those lab studies show that if you kept your dilution or your ratio of PRP to lidocaine less than 1 to 1, uh, it didn't seem to affect the platelets as much. And if you kept ropivacaine, ropivacaine is your preferred, lidocaine is your second. Don't use bupivacaine, and at a maximum ratio of a 1 to 1 dilution. Now, if we look at back at the slide I showed, I had a 5 cc thing of lidocaine, and half of that ended up in the muscle and bursa, so 2.5 into the joint. Then I used about 6 cc's of ropivacaine. So overall, probably 8 cc's of lidocaine when I'm putting in 11 cc's of PRP, and that patient had 17 billion platelets, so pretty concentrated. And then I'm additionally adding all of the protein-rich plasma, which is further diluting that lidocaine. So like I said, I don't know what the right answer is here. I know I'm trying to keep it less than a 1 to 1 dilution, but I'm also trying to get enough of a anesthetized shoulder that they can put up with the procedure and the manipulation afterwards.
Okay, thank you. And just one more procedure question. For capsular access, do you prefer an anterior over posterior approach?
Yes, definitely rotator cuff. Actually, well, rotator cuff interval to be specific. So that would be the anterior approach I prefer. And there are
Okay.
studies to support that is a slightly better outcomes than the posterior approach.
Okay. So it was like pretty obvious from just after the video that range of motion like improved like right away, quite drastically. But based on what Sina talked about, the inflammation is likely due to due is likely what's causing the pain response. So how quickly do patients report improvement in pain symptoms?
Yeah, when we do this, that's one of the nice things about the steroid, right? The steroid, they get better pain quickly. So usually, 3 or 4 days later, they're pretty happy. Both patients are happy with the range of motion early on, but the PRP patients are usually slower to get improvements in their pain, and they're getting, gradual improvements every month. Uh, I've seen patients report improved pain though in the first week. It's just not as drastic as the steroid patients. I think their improved pain in that first week isn't because the PRP is working that quick. It's just because they have a larger range of motion that they can get to before they feel that pain, right? But if they get to that end range, they're still in pain.
Okay. Thank you. And more of a demographic question. So, frozen shoulder is most common in women aged 40 to 60 and folks with diabetes. And I was just wondering, do you see any difference as far as the response to the treatment with patients who may have like some kind of metabolic dysfunction or anything like that?
Well, we diabetes is a metabolic syndrome, so
Right.
I haven't. I don't think I've done enough of these yet
Okay.
to say that I've seen a difference in PRP hydrodilations in patients with diabetes versus ones without. Now, we do know, though, from our steroid data that diabetes is a negative prognostic factor for these injections. So I would assume they're not going to do as well as your, you know, otherwise healthy insidious onset or post-traumatic onset of frozen shoulder. Now, this patient was 45-year-old male. He had a labral tear. I think you can also be thinking about should you be doing PRP or steroid based on what else you see on the MRI. So I did a lady today with a PRP hydrodilation, and she chose it because she knew that she had an articular sided rotator cuff tear, and we didn't want to put steroid around that. So that's why we chose PRP in her case.
Okay. All right, great. Thank you. I think that's it for questions this evening. Thank you both so much. That's great. Lots of insights and lots to think about with the future of this kind of treatment. I have a few brief announcements. I would like to share my screen just quickly, and then we will wrap up. Let's see.
Thanks for your questions.
Okay. All right, so this is the Pure SP device that Dr. Lotska talked about, and if you notice, we now have a 90 ml device, which gets us closer to that 10 billion platelet dosing benchmark that was mentioned. This device actually, MSite is guaranteeing the 10 billion. So Pure 2 device is going to be phased out, and this device, Pure SP with Aspiridome technology, will be the primary device available. So if you haven't made the switch, then please do so. It's an excellent device, and the platelet recovery is fantastic. The core device, this is the device that was used to generate the protein-rich plasma concentrate. And it's available in two sizes. The 60 ml, which goes with the 60 ml kit, you can load about 25 mLs of plasma, and the 120 ml kit, it can hold roughly 50 mLs of plasma. MSite is coming out with a new bone marrow harvesting needle. The key thing to take away here is there is a very sharp razor quad tip for the new needle, which means there's a minimal effort to get a more precise, minimally invasive coring effect. So look out for this. This is coming up soon. And again, Dr. Lotska talked about dosing and doing cell counts. So the new Regenistet machine will be available soon. EMSITE is working on that. The cool thing about this machine is it also images the cells and platelets. So you have an imaging component in addition to accurate platelet counts. And finally, the EMSITE Power Sales app is a handy tool. It provides a means to order devices, but also it has resources including publications, IFUs for how to use the various devices. It's the way to keep in direct contact with EMSITE. If there are any issues with devices, you can report them, do videos, and send them into the company and get a quick response. And so that's my last announcement. Thank you so much, everyone, for being here and for participating and for taking the time to advance your knowledge about regenerative procedures. We appreciate your time. Thank you to Dr. Lotska and to Dr. Farzaneh again. Those were excellent presentations, and everyone, we'll see you at the next webinar. Thank you.
Thank you for joining us in this session of EMSITE's webinar series. Stay tuned for our next episode as we continue uncovering the science behind precision biologics.